Good afternoon, everyone. I'm Amy DeZern from Baltimore, and Dr. Stevenson is always a tough act to follow, but that did bring back happy memories as I had a Cabbage Patch. No, but thank you. So just by way of introduction, will be our first panel session. It's talking about bone marrow failure, and I'm really looking forward to it. First of all, seeing so many friends in the audience, and then the wonderful colleagues that have given their time to make these talks. So just by way of introduction, we're going to talk about aplastic anemia, and we have 4 wonderful speakers from all over the globe, and their titles are there, and hopefully they'll each take about 10 minutes. If you'll come now and join me up here, then we'll have the opportunity for about 15, 20 minutes of questions at the end, and I'll be the last speaker, so if the IT people could put up Dr. Austin's slides now, that would be great, and mine will come up at the end. Thank you, Austin, for coming all this way.
Thank you. Thank you so much. While the slides are coming up, thank you so much for the AAMDS and also for Amy for this kind introduction. I think my take on 1983, nobody has mentioned cricket. I'm a big cricket fan. So India won its first World Cup in 1983, and I hope they'll do it this year as well. So that's my take on it. And so as the slides come up, so I was given this topic by Amy, so I'll try to cover it in 10 minutes. To be honest, I didn't know why that 40-year was up there until David and Mikhail started talking, so now I know. So there you go. So this is a very simplistic cartoon to understand what aplastic anemia is, courtesy of Antonio Risitano, and it's one of the paradigms of a pure autoimmune disease. So I think we've never seen a clear autoimmune disease other than aplastic anemia, where the target is the stem cells in the bone marrow and the attack is there. And as David mentioned before, this yellow bone marrow, which was first described as shown there, which he's gone through. And for people interested, please go and look at all David's tutorials. It's been amazing. So learn a lot from the history, and I'm also a history buff as well. I've just enrolled in history of medicine course as well. So let's see how that goes. But I think David has given us a background for it. So as I told you, this is a pure immune pathogenesis in aplastic anemia with various implications of the attack on the stem cells, including the number of components as indicated there, not just the CD8 cytotoxic T cells, but also the T regulatory cells, where a number of work has gone in from a number of colleagues as well. I think one thing which hasn't changed, and I don't think so we should change, is the definition of aplastic anemia, which goes back many, many years back to severity as defined by Bruce Cometa. And again, David also mentioned about what's there in the nomenclature, because with aplastic anemia, as you can see, there has been a number of different terminologies which has been used. I think my favorite is the toxic paralytic anemia, while somebody tried to mix it up with myelodysplastic syndrome with myeloaplastic syndromes as well, and type 1 and 2. I don't know what that meant, but thankfully, we've not changed the name as of yet. So I think this is just a schematic of how, as we go through in our center investigating these patients with presumed presentation with underlying pancytopenia with the possible diagnosis of aplastic anemia. And things have evolved over a period of time as well. I still remember the times when we routinely, everybody got banked with their blood, bone marrow, and skin biopsy for looking at it, and that has served as a big resource of looking at the genomic profile of this. And we were also, for suspected patients with constitutional, we were also doing CT scans for fibrosis, and also FibroScan or elastography, as it's called here in US, to look for liver fibrosis as well, and the consanguinity. Apologies, David. Next time I'll do a square graph for this, but there you go. But the basis for this is the number of genes. I think this is a credit to the genomic era in the last 10 years. This has gone up, and I can keep putting number of genes as well. There is one gene described in the context of inherited bone marrow failure every day and age. And last week we found a patient with DDX41 who was treated as aplastic anemia with a fantastic response to cyclosporin for 5 years until the brother came in and presented with AML. So even patients with DDX can present with a significantly hypercellular marrow. And this is something for the next 40 years. There is still undefined group of around 30 to 40% of patients with inherited bone marrow failure still going on. And this is a great work from the NIH group with Fernando looking at ability of machine learning and also to be able to predict if a patient presents to us in a clinic, can we differentiate by these tools using simple clinical markers and also telomere length to differentiate between inherited and acquired bone marrow failure syndrome. So again, we've come a long way in identifying and delineating inherited versus acquired aplastic anemia. But loads of work initially from Amy and recently from Daria's group looking at predictability of these PNH clones, acquired 6p-LOH, and TCR gene rearrangements in ability to predict an inherited versus an acquired bone marrow failure syndrome has always been very helpful because we know cytogenetic abnormalities like trisomy 8, 13q, and del6p have been significantly associated with an underlying immune component to the aplastic anemia, and at least with the 6p-LOH, that has only been possible with use of SNP karyotyping and advanced tools to detect this as well. What about mutational profile in aplastic anemia? So the basis for this is when we first described this presence of mutations in aplastic anemia, nobody believed it because at that time there was no age-related clonal hematopoiesis described because the concept of age-related clonal hematopoiesis was not described. So whenever we said patients with aplastic anemia and 20% can have acquired somatic mutations, it was thought these patients were all hyperplastic MDS rather than aplastic anemia. Now we know for clearly that these mutations are present in up to 20% of patients with that. And this is taken from one of Daria's reviews showing that we should not be worried about clonal hematopoiesis in aplastic anemia. It's more of a rule rather than an exception. So if you look deeper, you probably can find clonal hematopoiesis in about 100% of patients with aplastic anemia with varying techniques as well. Lastly, this concept of hypoplastic MDS or hypocellular MDS, till 2022, it was never recognized as a nosological entity in MDS, but as we know, it is recognized now in the WHO 2022, but not in the ICC, but we won't go into that, but essentially indicating that there are a number of other features and also the evolving role of immunohistochemistry and other things which has helped us to differentiate these dysplastic megakaryocytes in this context as well. And we did come up with the scoring using with the Pavia group to see whether if a patient presents with pancytopenia, can you use the genomic abnormalities to delineate and differentiate patients presenting like an immune-mediated aplastic anemia versus patients who are more towards the hyperplastic MDS spectrum. Lastly, looking at mutations, this was already shown, like 30% of patients did have the genomic abnormalities at baseline. But one of the cautions, again, which is important, is that when you look at the level of these mutations, they were extremely low, as shown in the right graph. Most of these mutations were present at diagnosis at an extremely low level. So if you look at it, the variant allele frequency in half of these patients were less than the 1% cutoff as well. So that is important again. So if you find multiple mutations or VAFs higher, then you need to rethink your diagnosis and say, is it really aplastic anemia or is there a component of hyperplastic MDS? And as you know, during the course of the disease, the mutations increase. This again shows just a spectrum. So some of the data is still unpublished, looking at a large cohort of 291 gene panel. This is the one which showed that nearly 95% of these patients had mutations with the VAF levels around 0.5% or less than that as well. So again, indicating the role of this. And when you look at the 4 commoner mutations and the spectrum of how they behave, this is something which is something we are working to see what does this mean in this context. So I won't go into that, but just essentially to say the word clonal evolution, again, we use it a bit loosely. For me, in the context of aplastic anemia, the only evolution is transformation to MDS and AML. That is when we need to intervene rather than just to the presence of the mutations alone and the predictability of risk factors. So just to sum it up, how we understand clonal hemopoiesis in the context of acquired immune-mediated aplastic anemia is in the context of a disease where there is depleted stem cell pool, which is under a proliferative pressure, and that evolving to either a malignant transformation or certain things which are neutral, which has got prognostic implications, at least during the course of the disease when we detect these mutations as well. And we still haven't 100% worked out, can we predict those patients with aplastic anemia who will evolve to myeloid neoplasms over a period of time? And that's something, as a community, we should look at it to see whether we can predict in the context of L. thrombophagia. So hopefully I've stuck to my time, but to conclude to say that I think with this, in the last 40 years, we've sort of become better to differentiate between inherited and immune-mediated aplastic anemia. The never use mutations alone in isolation in the context of aplastic anemia. Mutations doesn't mean that these patients have got MDS. Ability of the techniques, and also in the context of acquired mutations during the course of the disease, we are slowly getting there to identify and elucidate mechanisms, biology underlying this as well, to predict transformation to MDS AML. Thank you.
Thanks, Amy. Good afternoon. Thank you for the invitation, and congratulations again to the foundation for this meeting. I am certainly honored to be here. My assignment is indicated here. This is what Amy gave me, and I will try to, live up to that. So here we start. You have seen plenty of slides showing empty marrows, and I've taken the liberty of putting together a list of some of the early investigators. Don't be offended if you don't see your favorite hero up there. We heard already about the contribution of Johns Hopkins and the late George Santos, certainly to the development of the foundation, and there are numerous others. To be listed here, you had to have two qualifications. One, having made a contribution of significance to aplastic anemia, A, and B, to be 80 years of age or older, or would have been today. You see some of these, I met all of them except for Georges Maté with his early ATG work, etc. But all of these people have certainly made substantial contributions. One did win the Nobel Prize, and in my opinion, there is certainly one more who had deserved it, John van Rood, but that is how history goes. The big issues in the early years were the tissue matching, HLA, sensitization and rejection, conditioning regimens, and GVHD and its prevention. This is one of the early articles. Again, you have seen already a couple of those. I won't dwell on those. People from a number of different institutions from the East Coast to the West Coast sticking their heads together and certainly pooling their data together to begin to develop a more systematic approach to transplantation for aplastic anemia. Now, the essential drug that was used in the beginning and still is being used today, maybe less, it was cyclophosphamide. And basically all the early studies, trials included in the conditioning regimen cyclophosphamide. First, some comments about studies and results in transplantation from HLA identical siblings. This is a summary put together by the late Mortimer Borton, some of you may remember, who is really essential in establishing the CIBMTR, or IBMTR called at that point in time, on I think 140 or so patients. And you see about 40% still, that is respectable. Those of you, and there may be some in the audience, who saw patients before the options of immunosuppression and transplantation came along, these patients died from bleeding, infections, and from iron overload related to transfusions. They looked like they had been at the Riviera for a few months, brown all over, I can tell you, just on the side, I was involved in my first transplant from one of those patients on the day I got married. Just so happened. Then recognized, I said, sensitization was an important issue. And this is certainly where my former mentor, Dr. Storp, made his major contributions. How can we overcome sensitization, or can we sort of sort out what is going on? And what is shown on this slide from early data is a striking difference in the outcome of transplantation from HLA identical siblings, dependent upon whether the patient had received a substantial amount of transfusions or was untransfused. Clearly, results in patients who were untransfused were superior. Some of the early studies showed rejection rates as high as 40%. So clearly, this was a major insight. Of course, what do you do if patients are transfused? These patients were conditioned with cyclophosphamide, got bone marrow as a source of stem cells, and what we called a long course of methotrexate intermittently until day 102 after transplantation. Now, let me go back for a moment. The Paris team tried one other approach using total lymphoid irradiation. Certainly, Elian Glückman was instrumental in that. And that was quite effective in overcoming sensitization, but the toxicity, acute and particularly long-term toxicity, was substantial, and that approach was abandoned. What the Seattle team did here was to add buffy coat cells collected from peripheral blood to the bone marrow inoculum that was based on studies in the canine model. And lo and behold, with the addition of buffy coat to the bone marrow, the rejection rate was reduced. It didn't quite reach the level of untransfused patients, but results were substantially better. However, there was a price for that as well, and the major issue, adverse effect, was the development of graft versus host disease, both in its acute and more so even in its chronic form. Certainly undesirable, since in aplastic anemia, being a, quote, benign disease, from that point of view, there was no benefit from this graft versus host disease, where there may be benefit in patients with leukemia, as we know. I had developed at the time in the canine model a regimen where we combined methotrexate, cyclosporin. I will say here very bluntly, I did that against considerable opposition in-house. But when it was shown to be successful, everybody had done it, of course. So for the patient, of course, it didn't make a difference who had developed it. There was a significant improvement in the prevention of graft versus host disease, and the regimen still is used in some centers or for certain indications today. Other combinations are being used, of course. We will not go into detail of those. But this difference was quite striking. Now, as things evolved, other agents came into use, and in red here I indicate the two major ones, ATG and fludarabine. And this is a summary of data collected over a number of years by the Seattle team, in which cyclophosphamide was combined with the use of ATG, again, HLA identical sibling transplant, with the survival rate in the range of 88%, so certainly most encouraging. That is confirmed, or concurrently was also shown by a number of European studies. Andrea Bacigalupo, at the time in Genoa, has summarized a lot of those data, and the point to be made here, as you can see, if my pointer, well, maybe not. If age was a factor, clearly in the outcome, and when he used, or when the teams used fludarabine, ATG, or Campath, the results in the older patient, 40 years of age or older, moved up, shown in red here, moved up very close to what was achievable in younger patients with a survival of around 75%. These are multi-institutional studies, so that was certainly a major step forward. Let's move on to unrelated donors. We had carried out a, should we say, oligo-institutional study trying to add total body radiation to the conditioning regimen. It was a dose de-escalation study. We started at 6 gray or 600 centigrade in combination with cyclophosphamide and ATG, as indicated here, and de-escalated dependent upon engraftment and toxicity. And shown here on the left side is a comparison of patients younger than 20 years of age and patients older. There is still a difference, as I just showed on the previous slide, but the gap between the two age groups clearly has narrowed, and we settled for 2 gray or 200 centigrade, and that was then tested in a larger study published in Lancet Hematology a few years ago with Paolo Andolini leading that, showing that with unrelated donors, given a combined therapy, as shown here at the bottom, including total body radiation at a dose generally of 2 gray, we did some with 4 gray, fludarabine, ATG, and a low dose of cyclophosphamide, eliminating some of the cyclophosphamide-related toxicity. And you can see the results were excellent. It was in the range, with unrelated donors, matched for HLA, in the range of 90%. This has been done by other groups as well. These are, again, a European study from the UK, showing excellent success, in this case with the addition of Campath rather than ATG, the anti-CD52 antibody, and improvement also in older patients, older than 50 years of age. Just to emphasize that point, that is quite important. In many of the even recently published studies, the median age of patients has been in their 20s. So this is certainly an important observation. And as Judy Marsh from the same group published already earlier, it was interesting to see that a good number of these patients had mixed donor-host CD3 lymphocyte chimerism, which I think there is still debate, but is probably a major factor in establishing tolerance, and by doing so prevent graft versus host disease. Of course, the challenge has always been to prevent rejection as well. So in summary, remarkable progress has been made with transplantation in aplastic anemia. Results with matched unrelated donors approach those with HLA identical siblings. Rejections do still occur, but are really infrequent. GVHD is still an issue, as I pointed out, but with modified conditioning regimens and prophylaxis, the incidence has steeply declined. Thank you very much. This is my 26-month-old, I think, granddaughter, Tamara, looking into the future. I realized when I put that slide in, when she is as old as I am now, we will have opened the door to the 22nd century. Thank you.
Thank you. That was excellent. Now Dr. Patel will talk to us about immunosuppressive therapy. And I'm getting the sense everyone didn't love the titles they were given, but I think it's a really wonderful overview of why we're here.
Thank you, Dr. DeZern. I actually do love my title because this is what I do currently. And in 1983, I was just a fetus. So the progress made in treatment of aplastic anemia patients is evident with the improved overall survival that you see over the past decades. In 1990s, you see that the combination of horse ATG and cyclosporin provided a survival benefit of 60%, which has now improved to nearly 90% on a recent update done on patients who were treated with immunosuppressive therapy plus eltrombopag. And this is actually, from many different factors, not only just the improvement in the frontline immunosuppressive treatment, but also better outcomes that are seen with salvage transplant in the second-line setting, not only for young adults, but also older adults, and also supportive care, from transfusions to better preventative and therapeutic antimicrobials that are available. Having a response to immunosuppressive therapy has been a consistent predictive and prognostic marker. As you could see, in 1990s, the treatment of horse ATG and cyclosporin, if a patient was a non-responder, the survival was less than 20%, but this, while it is improved, it is still poor in patients who do not respond with the treatment of L-trombopag addition. In the 1990s, horse ATG and cyclosporin combination was shown to have a response rate of 60 to 70%, but majority of these responses were partial, with most patients having incomplete count recovery. And efforts were made over the next several years to improve on these responses by addition of additional third-line immunosuppressive agents such as sirolimus, mycophenolate, or replacing with a more potent antithymocyte globulin such as rapid ATG, or with cyclophosphamide were unfortunately not very successful. The improvement in the responses were seen with the addition of L-trombopag, a thrombopoietin agonist. It was not the first time where growth factors were added to the immunosuppressive regimen, but the most remarkable improvement in the hematologic responses were seen with the TPO agonist. Recently, it was in the randomized controlled trial performed in Europe. It was shown that the addition of L-trombopag, or confirmed rather, that the addition of L-trombopag resulted in a rapid and a more robust count recovery when compared to patients who were treated with immunosuppression alone. What about other TPO agonists? The other agonists, including romiplastim and avatrombopag, are being studied primarily outside of the United States, but they are early in their trials. The trial with romiplastim in the refractory setting reported that there was tri-lineage responses in about 40% of the patients, and the highest responses were seen in the platelet lineage. Interestingly, they reported low rates of clonoevolution, which was surprising because in our studies with L-trombopag, we observed rather higher rates of clonoevolution when used in refractory setting. The upfront trial in combination with immunosuppressive treatment has been completed, but the results are pending. Avatrombopag trial in combination with immunosuppression was reported last ASH with interim results, and they showed similar complete responses and overall responses. There are many trials that are ongoing, including one where the patients are refractory to TPO agonist, and they're being performed in China, and hopefully we'll get some updates in ASH this year. So we recently did an analysis to look at what were the long-term outcomes of patients who were treated with immunosuppression and L-trombopag. And to our disappointment, we found that the early increase in hematologic response with the addition of L-trombopag did not translate into decreased relapse rate. The relapse rates were similar to what was observed in patients treated with immunosuppression alone, in the order of 30 to 40%. But we did find that these relapses tend to occur earlier. As shown before, most of the patients who relapsed did get improvement in their blood counts by reinitiation of oral therapy. In this trial, either with cyclosporin alone or in combination with L-trombopag. As you can see in the table below, that some of these patients were able to come off the drug and still have ongoing response, but a subset did remain dependent on these oral agents. I think Austin had mentioned that clonoevolution is used loosely in severe aplastic anemia, and for our purpose, secondary malignant myeloid neoplasm evolution is described as high-risk clonoevolution in NIH studies, and this is defined as acquisition of chromosome 7 abnormality, complex cytogenetics, or a histologic diagnosis of myeloid malignancy. And this is observed in about 5 to 10% of patients, and unfortunately, again, the earlier responses did not translate into lower risk of clonoevolution, but these were similar to the patients who were treated with immunosuppression alone. As you could see on the right, these are the patients who had poor overall survival. Immunosuppression is often frontline treatment for patients who are older because they have higher complication with transplantation, or they're not eligible for transplantation because of comorbidities or poor performance status. Unfortunately, with the in the immunosuppression group, these are the same patients who have decreased response to frontline immunosuppression, and also if they respond, they have a lower event-free survival with increased relapse and evolution to myeloid neoplasia. As we know, hematopoietic stem cell pool is depleted by immune attack in patients with aplastic anemia, and this could be restored by means of immunosuppression or transplantation. Clinically, why I think this is important is because we often find that there is a delay between a diagnosis of aplastic anemia and standard treatment, whether it is transplantation or immunosuppression. And this delay could be for many different reasons. It could be because there is genomic studies that are pending for these patients, or that there is donor workup for transplantation, or merely because horse ATG administration is being determined at a tertiary care center, since it is not available in all hospitals. And while this is ongoing, in theory, there is continuous stem cell depletion, which could increase the regenerative stress, allowing for maladaptive clones to expand. And there is also ongoing high risk of decreased neutrophils and associated complications and higher transfusion burden. So with that in mind, our ongoing study aims at rapid initiation of oral therapy while awaiting for a full workup to get the patient to standard therapy, whether it is transplant or immunosuppression. So in this trial, we enroll patients who meet committed criteria based on their cytopenia and have a hypocellular marrow and have low suspicion for inherited bone marrow failure based on family history and also personal history and physical exam findings. And we initiate patients on low dose of cyclosporin and L-Trombopag, and once the workup is completed, they go to standard treatment. We are going to be presenting our full result from interim analysis at ASH, but I wanted to present a little bit that our primary feasibility endpoint has been met with no events in this oral treatment period of treatment-related severe adverse event, noncompliance, or misdiagnosis. But I think what's most exciting is that even with the median days of oral therapy of just 18 days, for most patients it was just a week, we see that there is improvement in the neutrophil counts and there is a trend in improvement of the reticulocyte count. I'm not saying that these patients are going to get a response with just oral therapy, but at least in theory, there is a halt of the immune attack. And looking at the secondary endpoint, till now the responses seem to be similar to triple therapy. And what we're observing with just a median follow-up of just over a year, that there are low rates of relapses and clonal evolution, but I think it's too early to tell whether this observation is real. And I want to pivot for the last two slides to show what we're working on currently. This is mainly work of my colleague, Dr. Groark and Dr. Feng. In our well-established mirror model, we have shown that ruxolitinib improves overall survival in these marrow failure mice. And it effectively treats bone marrow failure by increasing blood counts. It inhibits T cell infiltration in bone marrow and expands T regulatory cells. And based on this preclinical data, we are developing a phase 1/2 clinical study using ruxolitinib in a relapse refractory setting in different bone marrow cohorts, including severe moderate aplastic anemia, pure red cell aplasia, LGL, and hypoplastic MDS. With that, I wanted to conclude that we have made tremendous progress in achieving better upfront hematologic responses, and while there are also improvement in the salvage regimens. Relapse remains a problem, but this does not impact overall survival, but there are patients who remain dependent on immunosuppression for longer duration. I think the focus for the group who's studies immunosuppression should be on clonal evolution to myeloid malignancy, those 5 to 10% of the patients, and also those patients who are refractory to the initial treatment, because these are the ones who have poorer survival. And I'm encouraged that the rapid initiation of oral therapy is feasible, and at least we have early signs that there is early improvement in the early complications. Thank you.
All right, if you'll please put my slides back up. Thank you. So I think a lot of us were doing different things in 1983. It sounds like Bhavisha was a twinkle in her parents' eye. Mikhail was becoming a man. But I was actually starting my academic journey. So 1983 was the year I interviewed for kindergarten. And in fact, it still comes up at least once a month. Many of you know I spend a fair amount of time with my mother. And I neglected to draw hair on all the people on the entrance exam. And this was cited as a significant deficiency. But nonetheless, I have managed to devote some of my later academic career, not to hair, but to growing marrow. And this is something that I feel very passionately about. So you've heard from my colleagues about clinical evolution and some of the diagnostics, the matched transplants, which is very interesting. And I really find it very humbling if we look back to that diagnosis. We learned about the history with Dr. Ehrlich in 1988 of how much progress we really have made in this field. I think sometimes for our patients it feels slow, and sometimes for us it feels slow, but it really has been tremendous, and it's fun to think about. My task that I gave myself was how we're moving the needle a little bit more contemporaneously. And through the last 15, 20 years, so not quite all of the 40, alternative donor transplant has become a more accepted or at least talked about phenomenon. Upfront alternative donors started increasing in popularity, I really think, in the early 2010s and a little around 2008. And it's because a really nice paper that was presented at ASH initially talked about matched unrelated donors and even mismatched unrelated donors in the UK having similar overall survival. They looked at match controls in a database from the EBMT, and a small number, but children who had unrelated donors who did not get immunosuppressive therapy were still able to have successful survivals. And I think this is sort of the beginning of where we start to accept that this may be possible. China led the way in haploidentical transplant. They've used upfront transplant for much longer than the rest of the world. It has to do with their population, has to do with the available grafts. But one of the earliest retrospective publications was nearly 90 upfront haplos, which was quite controversial back in 2017 when this was published. But as it increased in the literature, the regimens for conditioning varied. Dr. Deeg gave us a nice overview of the way some of cyclophosphamide, cyclosporin, methotrexate, total body irradiation came in. And if you Google or PubMed in the more appropriate academic setting, you see a fair amount of alemtuzumab or Campath in different parts of the world. Certainly ATG has been the backbone of both immunosuppressive therapy, as you just heard from Dr. Patel, and this concept of TBI I'll touch on in particular in the alternative donor setting. Obviously, someone from little north on 95 can't talk about any aplastic anemia with talking about post-transplant cyclophosphamide, but it is so fun to look through the various publications from many of you in the audience, but also throughout the world, of how haploidentical transplant or unrelated transplant have continued to populate our literature. There are virtually no publications with these titles prior to 2010, but it has been increasingly popular in various ways. It talks about how we do the haplo matching. It talks about what conditioning might make sense. Is there the necessity to use a marrow graft versus a peripheral blood graft? And many, as you would expect, of the early reports were retrospective, but it really still brought up how we need to be moving the needle for these patients, which was my self-imposed talk for this. But we're really learning that haplos can be a viable graft, and as we heard, unrelated donors also considered an alternative source initially is something that really makes sense here. So the Baltimore regimen for aplastic anemia has been one of the more widely adopted conditioning and graft versus host disease prophylaxis regimens specifically for this patient group. And it incorporates much of what has been learned and elaborated on by Dr. Deeg. We knew that ATG was important. Rabbit may be better in this setting than horse. We know what we use in the immunosuppressive-only regimen, but this is certainly important in the transplant regime. Fludarabine is important. Cyclophosphamide at low doses pre-transplant is important. Total body irradiation does allow very high rates of engraftment, no doubt, and we still are quite beholden to marrow grafts in the aplastic anemia setting, and this may be a point of discussion during our time for chatting. And then intensive GVHD prophylaxis, as Dr. Deeg alluded to, that this is technically a non-malignant disease. Patients may take issue with that characterization, but it's true that we don't need the graft versus leukemia effect, so not having any graft versus host disease is particularly important. Something that is also important in our world is to study these type of interventions in a multi-center fashion to see if they can have success, even if they've been successful in one city. It doesn't always translate to a broader instance. But I think in this case it did. Using haploidentical donors, bone marrow, stem cell source, and the regimen that I just showed you was studied in the BMT-CTN 1502. It was a single-arm phase 2 and relatively small, but what we ultimately were able to show was that the overall survival was favorable, matching some of what you heard from Dr. Patel for immunosuppressive therapy, but in a highly refractory patient population. And back to my point that we don't need the graft versus leukemia effect here. The graft failure-free survival without graft versus host disease, which is the GFSS, also very favorable for patients that otherwise can have quite unfavorable outcomes. And the rates of graft versus host disease using this intensive regimen are quite low. That's important to the patients. So when something works in the second line, and I suspect we'll hear this a bit in the MDS talks, we just move it to the first line. Gets back to history doesn't always repeat itself, but it certainly may spur us along. And so this is an algorithm that many of us have seen. It's squares, not circles, but I think you do notice a theme that once we make a diagnosis, as Austin so eloquently shared with us, of severe disease, we really have to think about what to do in terms of their therapy. And alternative donor transplant, in this case haplo, is moving forward in the therapeutic arsenal. This is our own publication looking at patients who did not receive immunosuppressive therapy, had haplo-identical donors available, and were treated as their first therapy. This is what I think about when I know we're all still learning. The first 7 patients on this clinical trial were treated with 200 centigrade total body irradiation. And unfortunately, those 2 downward trajectories of the green line were the 2 patients that had adverse outcomes in the setting of 200 centigrade. Since we've increased it to 400 centigrade, again showing the value of being thoughtful about our conditioning, we have 100% survival. And that's survival that's very comparable in the relapsed and refractory or treatment-naive setting to immunosuppressive therapy and other regimens, and this may in fact represent a cure for these patients. Uniform conditioning is something that I think is important in the transplant field. When you have a habit and you're good at something, you're usually that much better at it. And so bringing in some of what we heard about alternative donors, specifically unrelated donors from Dr. Deeg, this particular regimen is increasingly used when somebody doesn't necessarily have a haplo, but they either have a mismatched unrelated donor or a fully matched donor. I think our colleagues in pediatrics are incredibly good at thinking about high levels of evidence and how we should design trials that answer the hard questions. And this gives me the opportunity to talk about the transit trial. And this is a flavor of trying to decide if alternative donor transplant makes sense for compared to immunosuppressive therapy for aplastic anemia. So in this trial, led by David Williams and Mike Pulsifer, patients are diagnosed with their marrow failure disorder, namely aplastic anemia, and they have a very rapid screen through the NMDP. If they don't have any, either 9 out of 10 or 10 out of 10, which are considered fully matched unrelated donors in this setting, they would not be eligible. But if in fact they have those donors available, then the individual patient up to age 25, which is why it's a pediatric trial, is randomized between immunosuppressive therapy or unrelated donor. There's been a little bit of early data published on how this trial was designed. We're looking forward to additional results once more patients have been treated. But I think it really is moving the needle of maybe we don't always have to have a matched sibling for an upfront transplant. And then we're trying to push the envelope in the same way with haploidentical transplant. This is the CURE-AA trial, which is using upfront haplo transplant or unrelated donor that can be mismatched in patients aged 9 months to 75. That is the next aplastic anemia trial coming through the BMT-CTN. It's a little larger than that initial 1502 study by 2. This is a 60-patient trial. And this is really intended to broaden transplant as an upfront option to an incredibly diverse population. One potential limitation to the transit trial is there still may be many people who identify as minorities who do not have 9 out of 10 or 10 out of 10 unrelated donors. And if you have a haplo donor, you can be of any background because they're related to you, or we go down pretty low in terms of mismatch for unrelated donors. So I think it's really something to think about. And as we continue to move the field forward, at least in the transplant aplastic anemia arena, trials like this I think are really going to provide illustrative data that help us understand if this is a reasonable first therapy for everybody. These two trials are not able to be compared directly, but I just show you some relevant metrics and how we're trying to ask the hard questions. The transit trial is much larger, you can see that. The graft versus host disease prophylaxis is a little different between the two, and our total body irradiation dose is a bit higher in the CTN. That has a little bit to do with what pediatricians are willing to accept in terms of toxicity from total body irradiation, and perhaps what adult transplant physicians may be willing to accept. But I think it's an open and interesting question. The primary endpoint is phrased differently in each trial, but it really is trying to understand how we make the lives better for our patients with aplastic anemia. We don't want to give them graft versus host disease. We don't want them to have clonal evolution. We want them to be cured, back to work, and not need another therapy for their aplastic anemia. And both trials are derived around what I think is a laudable goal there. All right, so in summary, we've had a lot of changes to conditioning and GVHD prophylaxis, including post-transplant cyclophosphamide over the years. And I do think most people agree it has improved the safety and efficacy in transplant-eligible patients of alternative donor BMT to acceptable levels in the current era and over the time course of the AAMDSIF mission. No longer is transplant required as only something at the time of failure. We can use it in the upfront setting. And these trials that I highlighted, I think, may really add to the field. And I think what it's about for all of us is really moving from an older paradigm to a newer paradigm, and it's really fun to be a part of that, and we're all quite grateful for AAMDS' place in that world. So with that, I would like to have us all sit down, and I hope the audience will ask some questions, or my colleagues may certainly start as well. Perhaps I'll start. I actually had a question for you, Austin. I love the slide about the T-cell attack at the level of the CD34 progenitor, and I even explain it to patients like that. But I think in the era of sequencing and better knowledge about syndromes like VEXAS, I worry that maybe we actually don't know the whole story. Do you think there's opportunity or potential for other parallels between the immune system and the hematopoietic system?
Yeah, I think, although I think it looks nice on a picture, is it? But I think there is more to it, I think. So the fact that we don't understand the type of antigenic attack and what is cross-reactive. And I also say that as we say it's a definition of an autoimmune disease, but we've not found an antibody, unlike other autoimmune disease. So that also has a factor in. So I think there are quite a lot of things, because when we did the T regulatory cell work, there was no background data on the role of CD4s in this as well, but it seems to be very relevant both in the pathophysiology of the disease and, as Bhavisha showed, in the data from the RUX as well, that seems to have a role in recovery of hemopoiesis as well. So there are quite a lot of things we still don't know.
Fair enough. For the next 40 years.
I would like to add that we don't even know how ATG works. Being rather crude agent, and I remember many years ago, 2 grueling years of trying to see whether ATG has direct effects on bone marrow stem cells and what does it do. And it was very, very difficult. We didn't have much conclusion, including the fact that some of the control was pre-immune horse serum had very positive effect on stimulating CD34 cells growth in vitro. So the pre-immune horse serum had very positive effect, was very, very difficult. So there is a lot that we don't know. And by the same token, the question of early treatment is I think, a very important topic, and I don't know that it will nail it on a head, because we all have these experiences of a patient who inadvertently was not treated properly with immunosuppression, received growth factors forever, and only after many years I asked myself, well, ATG is not going to work, and guess what? After many years, patients who were, if you wish, mismanaged, get ATG and have full remission. So the idea that, you know, this is a ubiquitous or general mechanism, that there is a constant attrition, and I think moderate aplastic anemia is another example, it might not be true for every patient.
Thanks. I think Dr. Gore had a question.
Yeah, thanks. Thank you. So, you have noticed, thanks. It's good to have friends. That's what Bette Midler said. Anyway, you know, as a aplastic anemia adjacent physician, as always kind of observing from the side, over the years, you know, there was, first got into the field, there was, you know, transplant was really appropriate for kids or for adults with very good matches, and then immunosuppression was okay, but, you know, and then transplant kind of caught up and immunosuppression got better, and then, but that was only for people with donors for transplant, and now we've got all sorts of different donors that are acceptable, and now we've got pretty good, you know, really quite good outcomes with immunosuppression, but there's still later clonal diseases. So again, and not even, now I'm clinically adjacent. I'm, you know, that was really just a philosophical question. Has the choice of appropriate first-line therapy now become a patient-directed informed consent decision? That, you know, overall, we can transplant you probably. Yeah, I'm talking about somebody who's healthy enough for transplant. We can transplant you probably. We can probably find a donor. You probably will respond to immunosuppression, and here's kind of the pluses and the minuses, and this is just a very difficult informed consent decision, or are we going to figure out a way to have machine learning figure out what to do here for patients?
So I think it's a great question, and I love having these conversations. And I just said to Dr. Patel that we share a patient, that I'll just share the anecdote because it's exactly embodying what you are talking about. She actually is a medical student, and so she's educated, she's kind of middle-aged in the transplant world, so she's 25, right, falling on your curves, Joachim. And she had, interestingly enough, hepatitis-associated aplastic anemia that met criteria for severe disease early on. And she had some personal beliefs that meant fertility was important more than anything. She also has a fully matched brother. And these were interesting discussions. I'll let you comment first.
Yeah, so I met this patient first, and obviously given her age and the fact that she had a matched sibling donor, I told her, go get transplanted. And she, after considering all the things that you highlighted, decided that she wanted to pursue immunosuppression first. In addition to the fertility, I think what was also important for her was not missing school and not taking a break. And she did, and she responded very well. She did have a low-risk evolution, which, you know, we have transient, sometimes chromosomal abnormalities that come and go. But you're absolutely right. More and more to older patients, I'm having these discussions, not only when they have matched sibling donor options, but also when they have matched unrelated donor options, because now we have older patient population that are just as fit as younger ones, and the transplant outcomes have improved. So it has become a more patient-directed decision to enroll on our trial to get immunosuppression, or at the least I advise them to go and talk to a transplanter. So that way you have heard all the information for both of the treatment options, and then they decide.
May I, sorry, can I chip in some comments here? I think your question requires a separate conference, quite frankly. No, I am not trying to be funny. These discussions are sometimes endless. I'm always torn between sort of listening to the patient, which is essential, and making recommendations from a, quote, expert point of view. Because in the end, I think it's not any offense here, it is sort of lazy to let the patient decide. Yes, you want the patient's opinion, but I think it is your decision what the best treatment, in your opinion, is. I mean, I could go on for that forever, but as I wanted to add something that sort of combines conditioning regimen and age, what we, like everybody else, has noted that results with transplantation, even with fully matched transplants in older individuals, when I say older now, I mean 65, 70 years of age, just we are not as good as in younger patients. We're in aplastic anemia, whereas in patients with, quote, myelodysplastic syndrome, we had excellent results. Median survival in some of those studies, 65 years of age. And so I think that is another aspect that goes into that conversation. And in fact, we, meaning the Hutchinson Cancer Center, has started to apply MDS regimens, or what we considered MDS regimens, to patients with aplastic anemia. And that is not even considering overlap and what have you. I mean, it becomes very complex. But interestingly enough, with different regimens that often do involve low-dose radiation and fludarabine only, non-myeloablative regimen, have been quite effective. So I think that discussion will still go on, but I think I return to the starting point. I don't think there is a clear answer at this point.
Can I ask a question for both Dr. Deeg and Amy as well? Because he presented some data on de-escalation of TBI going down, and you talked about going from 200 to 400. Where is the sweet spot? And because I'm mainly worried about late complications, fertility, and other things.
Your question is a fair one. I do feel somewhat confident, mostly confident, in the fact that to enable engraftment with a haplodonor for treatment-naive aplastic anemia, we need more than 200. It may be that we only need 300. We haven't looked. 400 is clearly sufficient, and so you're right. We need to think about this. And I will say, a lot of the conversation that I have with patients that are worried about fertility is that I do not know if 400 is fertility sparing. So I think it's just an open question, and I'll just mention that the transit trial does not have 400, it has 200 specifically for that issue, and a lot of long-term outcomes looking specifically at fertility because their patient population is younger. But I'm interested to hear what Joachim says.
Well, just in regards to fertility, which has been a difficult issue for me to discuss with any patient, quite frankly, because my concern is about the patient, not the next generation. But that's, again, a different issue. Sorry for that. No, I'm not sorry. So there are, in fact, some data, and some of you may know those, that Dennis Hickstein at the NIH presented in a canine model looking at the dose of radiation and its effect on fertility. And certainly in the canine model, fertility at those doses, 2 to 4 gray, was quite well maintained. That doesn't mean one can sort of count on that in humans, and certainly there are no long-term observations as far as mutational problems are concerned. So if we can avoid it, I think we should avoid it. But I think the fertility would, for me, in my discussions, not be a major issue. Because again, this becomes so personal that I don't think one can make general recommendations.
Fertility is never going to be an AI issue.
I think I'm convinced we will see data on that. Absolutely, absolutely. But I cannot speak to that. That is beyond my competence.
Mortality rate predicted would be only 10%. Now imagine that you have a revolver with 100 bullets. with 100 empty spot and you have 10 bullets and you roll. I mean, any healthy-minded person would have hard time rolling this Russian roulette, right?
Well-
So the mortality, on the other hand, you could say mortality rate 10%, this is great result.
I try to avoid firearm metaphors in the clinic, but I always say all we need is 100% in this room. And your point is well taken, that it's really about this individual patient, and that's what we're most worried about. I actually had a question about, let's call them platelet growth factors and combination with immunosuppressive therapy. Your group has shown great data with EPAG, but you mentioned that looking at romiplastim and avatrombopag in places where perhaps L-trombopag is not approved really has merit. And I wondered if you could expand on that, please.
Yeah, I think as I mentioned in my presentation, they were still early in the development, but the data that we have seen seems, at least with the romiplastim, that they may be effective in some patients who are refractory to previous L-trombopag administration in the frontline setting. I don't think the data is all together yet to really make definitive statements. And the second thing I would mention is that I did present that they reported lower clonal evolution with the romiplastim, but looking at the composition of the patient cohort, it seemed like they included both moderate aplastic anemia patient and severe. And that was our experience as well, that when non-severe patients are given L-trombopag moderate aplastic anemia, the clonal evolution rate is really not that high. So I think it's still to be determined. I hope it seems like avatrombopag may have many trials that should be reporting some interim outcomes this coming ASH.
And then a question for Austin and Joachim. Let's say you're seeing someone as a transplant consultation, but perhaps they went with the early is better, and they're on L-trombopag and cyclosporin. Do you say, I've met you 4 weeks in and we're going to wait? Or do you say, so be it. Maybe your kidneys took a little hit in the first month, but we'll just go to transplant. What do you think about this early treatment approach as we roll into transplant?
I think the one thing I would say is, because I know it's different in different countries, the one thing we've done, and we do it for all diseases, is we do disease and transplant together. So we make that decision a bit more seamlessly rather than referring to a transplanter versus not transplanter. We've done that for MDS as well. So we take that discussion at the upfront side itself. So every transplant eligible patient, irrespective of the age, will have upfront tissue typing done, look for donors as well. I know the specific case is difficult, but for those transplant eligible patients, we do make a decision at 3 months to see which direction to go, not immediately transplanting because it will take time. We'll go towards the 4 to 6 months period, but we will make a call on it. We would reduce obviously, preserving organs for transplant is always important, so we would dose reduce, do alternate CNIs, or probably think of switching them to sirolimus as well in some context with cyclosporin tacrolimus toxicity if they have renal dysfunction.
Actually, our approach is quite similar. We try to do a comprehensive workup, including HLA typing and a preliminary search for an unrelated donor to determine what the options are. And again, very similar, we like to give at least 2.5 to 3 months after initiation before proceeding with the transplantation if there is no evidence of response at that time to immunosuppressive therapy.
I just wanted to add that with the low-dose cyclosporin, we haven't seen much kidney impact.
Good.
Go ahead.
No.
No, I just want one sort of modality that is evolving for other diseases at a almost breathtaking speed. In other words, CAR T cells and otherwise genetically modified T cells. Since we are talking about an autoimmune disease and targets that can be targeted by targeted therapy, I'm not sure anyone is working on it currently, probably yes, but I think that might indeed be another modality to keep in mind for the future, particularly for patients who are at high risk from side effects from conditioning, what have you. I think it will be interesting to see.
I have a question for Austin. So you alluded to somatic mutations in aplastic anemia. They're quite common, but there are mutations that have been identified as maybe predictive of clonal evolution or bad players, such as RUNX1. If you were to see a mutation like that at baseline or even at 3 months after initiation of immunosuppression, what do you tend to do?
Yeah, so thankfully we've looked at our cohort of the last cohort of about 110 patients. None of them had a RUNX1 or that type of mutation at baseline with the variant allele frequency more than 5%, which is probably the clinical cutoff for reporting. So we don't, and then I call into question if you're finding RUNX1 mutations and other things at diagnosis, I call into question about your clinical diagnosis. So it's not aplastic anemia, it's some form of a mild dysplastic syndrome. Yes, it is worrying that when you see these mutations at 3 months or 6 months, but we have a set of patients. This is the difficulty. Patients are well, they have a normal blood count, but they have a low-level RUNX1 mutation. So those patients are very difficult, and these patients we have monitored over a period of time. I know these are individual examples, but we've seen the clones going down and disappearing on reconstitution of hemopoiesis, although we were ready to go towards a transplant. So those cases are very, very difficult to make the decision, because one of the patients was a 19-year-old. She's still being followed up, and her RUNX1 mutation, even by ultra-deep sequencing, we can't find it now.
Any additional questions from the audience? Please. Alice, can you?
Do you think someone who's responding to immunosuppressive therapy should ever go off of it, an adult I mean, should ever go off of it, even homeopathic doses? So we've all seen patients where you wean them, we've all had the experience early in our careers where you take them off dutifully after they've responded, and they almost always invariably relapse, and then you get them back in responding, and you wean them down to literally homeopathic doses of cyclosporin, 50 milligrams a day or 3 times a week, or L-Trombopag 3 times a week. And that's maintaining their blood counts. When you come off of that, they drop their blood counts. So it's clearly doing something, it's having some beneficial effect. And so those high relapse rates you showed with the primary immunosuppressive therapy trials, because many patients were told to get off of the immunosuppression, could we have maintained those responses by just keeping them on very, very, very low doses?
I can answer the first bit, and then Bhavisha will chip in for the. So we are extremely conservative in UK, not the party, but we are generally conservative. So what we tend to do is we don't stop the low dose even at the end of 2 years. We keep them going. We achieve a blood count, CR, or a stable dose, and keep them going for at least 6 months on that dose, and extremely slowly wean them down, like 25 milligram every 6 to 8 weeks or every 3 monthly. And we have those patients. I've got a patient who's on 25 every other day. It's ultra homeopathic. And you stop the dose, the blood counts drop down. So we do keep these patients. And if a patient have shown that they've relapsed when you weaned off the cyclosporin, I never try to wean them back again. And those are the patients who, even at any sort of alteration to your immune system, like they get a vaccination, they drop their blood count. So indicating that their primary insult on the hemopoietic stem cells, the autoimmune attack, is still there at a low level, that if we withdraw it, then it's a difficult thing. But I think Bhavisha has got more experience on the L-Trombopag dependence, which is very difficult.
Yes, so first I'll comment on the cyclosporin component. So our approach is a little different. We do stop the low-dose maintenance cyclosporin developed by Dr. Scheinberg here at 2 years. And the justification for that is that 50% of the patients are not dependent on cyclosporin. So you do spare even the low dose in those 50%. The other 30% who relapse, about half of them do remain dependent. And after the first trial, maybe the second trial, if they show that they were dependent, then we also keep them on low-dose cyclosporin. Eltrombopag has similar story. I think for majority of them, we are able to slowly wean off the eltrombopag, and our attempt always is to wean off eltrombopag before we wean off cyclosporin because of the underlying immune-mediated pathophysiology of the disease. But there are a few patients that are also much more responsive to eltrombopag and are eltrombopag dependent, and in those we find the lowest dose, where their blood counts are stable, and we continue. But we monitor them very closely because we do not know what the long-term side effects from clonal evolution perspective in eltrombopag yet.
Because after so many years, it's not going to work, or how much it indicates that there are these ambers of the disease that are still glowing, and you need to, from time to time, pour immunosuppression on it. And I think this is one of the great needs that we have to think, how do we distinguish the scar and burned out autoimmune disease from a slightly sort of smoldering, if you wish, aplastic anemia?
Great, thank you. And thank you to my colleagues for excellent time on the talks and even better content. And I think now it's time for a break. Thanks so much.